When it comes to the disability exam, unfortunately, many patients get the most important part wrong. Today, I'm going to tell you how to get it right and give your disability application the best chance for being approved. Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. I've done over 1,500 of them. As usual, everything I say reflects my own opinions based on my own experience and learning, and not the opinions of the Social Security Administration or any other medical body. So what is the most important part of a disability exam? Well, most people have it backwards. They think that tests are the most important part. The all-knowing MRI will tell the doctor what's wrong with me, and nothing could be further from the truth. This isn't just my opinion. Scientific studies have been done examining how doctors come to conclusions about patients, and they all agree that the medical history, the way the patient describes their condition to the doctor and answers the doctor's question, is by far the most important part of the exam. The physical exam, where the doctor looks at the patient, listens with a stethoscope, and pokes and prods the patient's body, is the second most important part of the exam. And tests are a very distant third, usually used only to confirm the conclusions the doctor has reached based on the history and physical. So how patients describe their problems to the doctor and answers the doctor's question is the most important part of the exam. So why do so many patients get this wrong? I believe it's because they're not used to the format of a disability exam, which is very different from your typical doctor visit. In the typical doctor visit, the doctor focuses on two things. Number one, the diagnosis. What sort of injury or illness does this person have that's causing their problems? And number two, the treatment. How can I get the injury or illness to get better based on the diagnosis I've come up with? In a disability exam, number one, the doctor isn't focused on treatment at all, because disability exam doctors do not treat the patients they examine. They don't order tests, prescribe medicine, or give medical advice. And number two, the diagnosis, the exact cause of what's wrong with the patient, is much less important in a disability exam. In a normal doctor's visit, if a patient comes to me and tells me that they've become short of breath, I think, well, it might be asthma or pneumonia or congestive heart failure. And it's very important to determine what is the cause, because the treatment will depend on the cause. In a disability exam, what is the focus is what can't the patient do that's necessary for work, or what can they do but with difficulty that's necessary for work. Only work-related activities are focused on, and these include the ability to see, hear, sit, stand, walk, lift, carry, handle objects, speak, travel, understand, remember, concentrate, persist, interact socially, and adapt. If the patient has limitations that are not necessary or related to work, again, they're not very important in a disability exam. A disability exam is what doctors call a functional exam. The doctor wants to know how well you can function in a work environment. So I'm going to give you two examples, one of a almost useless patient history and the second of a very useful patient history with the same problem. So a patient comes to me and I ask them, would you please tell me about the problems you have that prevent you from working? And they say, I have an L4-5 disc herniation. And they think they've answered my question, when in fact I don't have a clue whether they're limited in their ability to work or not. The fact is, herniated discs are very common in people with no back trouble at all and give the doctor no idea whether the person can work or not. That's an example of focusing on the test. Now here's the person, but with a very good history. I asked them, can you please tell me about the problems you have that prevent you from working? And they say, I have this really bad pain in my back, and it often goes down my left leg to the outside of my foot. And it really hurts to bend over. I can't tie my shoes. I have to wear slides now. And if I stand for more than about 15 minutes, it hurts so bad that I have to sit down or lie down. I do have some Percocet that my doctor prescribed that helps with the pain, but when I take a Percocet, it makes me so groggy that I have trouble staying awake and thinking. Notice the difference. In the second case, the patient talked about how their problem affects them, and specifically how it affects work-related activities. They can't bend over. They can't reach things on the ground, which would impair their ability to lift. And they can't stand for more than 15 minutes. And standing is an ability that Social Security specifically wants addressed on all patients. They've also mentioned the side effect of their medication, Percocet, that affects their ability to work. They explained that the Percocet helps them with the pain, but when they take their prescribed medicine, they have trouble staying awake and concentrating. Again, those are work-related abilities. And I'd like to add here that side effects of your medications or other treatments, such as drowsiness or sleepiness or forgetfulness or dizziness that affect your work-related abilities, are important to describe to the doctor. Here's another example of a bad and a good history. I ask a person to tell me about their problem, and they tell me I have bone on bone in both my knees. Well, that's a description of their X-ray or MRI findings. It doesn't tell me whether they can work or not. Again, focused on the test. Here's a much better history of the same problem. Both my knees hurt. My doctors told me I have bone on bone. The pain gets worse if I stand or walk or go upstairs. I can only stand for 10 or 15 minutes, and then I have to sit down and rest my knees. And I can only walk about half a block, and then my knees hurt too much to go any further. And also, I can't squat down to pick up anything on the floor because of knee pain. In the second case, the person has given me very useful information about the limitations in their ability to stand, walk, and lift and pick up things from the ground, all important work-related abilities. And I want to add here that if you notice, the person was specific. They didn't say, I can't stand too long. I've always asked people when they tell me that, how long is too long? And believe it or not, I've had answers anywhere from 5 to 10 minutes to 5 hours when I asked how long is too long for standing. You need to be specific. if you can't do heavy lifting, what is heavy lifting for you? Is it 10 pounds? Is it 20 pounds? Is it 50 pounds? It's very important to be specific. And the reason is, unless you cannot do an activity at all, like for example, you're completely blind and cannot see, if you can do the activity but your ability is limited, Social Security grades it one of 4 grades: mild, moderate, marked, or severe. And the doctor needs to know if your limitation is mild, moderate, marked, or severe. And specific information that's usually related to time, distance, or weight is very helpful. Finally, Social Security wants to know if you can work now. And that means you need to describe your problems and limitations as they are today, not 2 years ago, and not how they might be if you have an operation 6 months from now. You need to stick to the now. Well, I hope this has been helpful, and as always, remember, if it happens, it's possible.